Well, good afternoon, everyone. Thank you so much for logging on for our webinar today. Really excited about it to discuss some of the great work us at the Coalition to Transform Advanced Care have been working on with our congressional partners. I want to first introduce myself and my team. I'm Jennifer Blemmer, and I'm the Director of Policy and Advocacy at C-TAC. Today, I'm joined by Brian Lindbergh, who is a Senior Public Policy Advisor at C-TAC, Marion Grant, who is our Senior Regulatory Advisor, and Mariset Hassan, who is our Senior Policy Advisor at C-TAC. Hopefully we'll be joined today by special guests, Asha Samuel, who is a Legislative Assistant for Rep. Earl Blumenauer. First, wanted to introduce you all to the Coalition to Transform Advanced Care. If you are not familiar, C-TAC is a coalition of 190 organizations that share our vision of person-centered care that meets patients' goals and honors their dignity. We represent the voice of patients and families, representing their interests and working with legislators, decision makers, and advocates to find common ground and craft policies that deliver more comprehensive, equitable, and consistently funded care at scale. Together, we're opening the door to a new healthcare paradigm built on greater equity, public engagement, and workforce development. What guides our work is our core principles for care models. Our core principles serve as the foundation for everything that we do here at C-TAC, and we continue to promote them and utilize them and encourage providers and practitioners to use these care principles for care models when considering healthcare for others. Now I'm going to turn it over to Brian Lindbergh to talk about our legislative policy priorities.
Thank you, Jennifer, and thank you all for joining us today. We're real excited about our meeting today. We have a special guest with us. We had two planned, but unfortunately, one of them is ill today, but we're going to talk about new legislation that's just been introduced. And just a couple reminders. First, my regular reminder that we're bipartisan and bicameral. We work on both sides of the aisle. We try to work both with the legislative branch and the executive branch to provide solutions to improve care for in the serious illness space. Here you see our broader legislative priorities and a commitment from us that at the core of our agenda is advancing equity and dismantling systemic barriers to high quality serious illness care for traditionally underserved communities. You can see there our top priority this Congress has been passage of a standalone advanced care planning bill to improve access, particularly for persons of color, to advanced care planning to ensure that they receive all the care that they want and that their preferences are respected and followed. Let's go to my second slide there. And this is just by way of introduction of our colleague today in Washington. We know that Hill staff make things happen. They make the difference often. And with their passion to public service, integrity, excellence, teamwork, and the desire to make an impact on the quality of life. And so we have one of our colleagues today with us, two of the best and the brightest we've been working with up on the Hill. Asha Samuel, who serves as the legislative assistant to Representative Earl Blumenauer, and as Jennifer mentioned, Colleen Nguyen was going to join us. She serves as a senior advisor to Senator Mark Warner. These two members of Congress have been our stalwart leaders in this space for many years, and continue to do that. Asha has been on the Hill since 2019 and also worked in Representative Pappas's office and also worked for the Better Medicare Alliance. Her master's degree is in public health. And let me see if she has joined us today before I introduce her. If not, we'll ad lib a little. The Hill is a busy place and sometimes it's hard to be right on time for the Zoom calls. Are you there, Asha?
No, I'm here.
Oh,
I
great.
apologize. I was a bit late going on and I'm a little bit distracted. Votes just got called, so it's a little bit all over the place.
Okay.
So I apologize if I have to do this a little bit more quickly than I had originally planned. But I appreciate you having me here.
Okay, great. We could go to the next slide, please. And Asha was so helpful in getting this legislation drafted, and really was a great example, I thought, of, facts matter. She really wanted to have all the background on these issues and get some data. We worked together very well on getting this drafted with Colleen. And she is going to walk us through the key elements of the bill. And then hopefully, if you have just a few minutes, we'll try and do some Q&A then, Asha, afterwards. So please take it away. And thank you so much for joining us.
No, thank you so much for having me. I know most of you probably already know this, but this is a huge priority for Congressman Blumenauer, and has been for such a long time. I think I feel like everyone might still have some scars about the death panels debate, but I think he wears that badge of honor proudly and often talks about how it was the lie of the year in 2009, this idea that paying providers to have these important conversations was somehow tied to rationing care, and when it's really the opposite, I think, is how we've been viewing it. And over the years, he had worked closely with the various members on both sides of the aisle to advance this idea that end-of-life care isn't about rationing care, it's about making sure that people's wishes are respected and enforced. And we were really happy to see that CMS decided to implement the codes on their own to reimburse for advanced care planning, and he started working on the Patient Choice and Quality Care Act. And as we kind of move into this world where the SIP model isn't necessarily happening anymore, and how do we think through the language that was in our previous legislation, we wanted to bring out some of the more smaller but key pieces on promoting advanced care planning and making sure that it's more easily accessible, especially when we're thinking about the impact on communities of color by some of the barriers that are in place already. And I think, he'll talk a lot about value and how much we're spending on healthcare, and when we really should be investing in things like this that will allow patients to be able to have their wishes respected and be able to, age with dignity, and also, not give them unnecessary care that can be really horrific. I think he brings up this story about from the New York Times in 2009 about a man who kept getting resuscitated when he didn't want to be, and it was so painful for the patient. And having those conversations ahead of time can really save a lot of heartache for families and for patients, which is why we wanted to do this legislation. And the two big things policy-wise that this legislation does to improve access to advanced care planning is removing the cost sharing for this benefit outside of the annual wellness visit. As you may know, it's already covered as a preventive service in the wellness visit, but not in other situations, which seems pretty silly when we're thinking about things like if you get a terminal diagnosis in an oncologist's office, that might be when you really need to have that conversation, but then you would have to pay out of pocket, which seems counterintuitive to what we're trying to do here. And then also to include licensed clinical social workers as one of the eligible practitioners, because they might be more prepared to have this conversation and can walk them through various situations, and also might be the provider that's available, especially when we're talking about the workforce shortages that we're currently facing. And then on top of that, when we're kind of thinking more broadly about what CMS can do, making sure that we're providing the right kind of education and on the codes, and making sure that providers are available, that they're out there to bill, and also directing MedPAC to do a study to evaluate the codes in the program so that we can continue to build on the work that we've already been doing and continue to make improvements as we look to the future, is kind of the gist of the legislation.
Thank you. Do you have a few more minutes, Asha?
Yes, of course.
Oh, okay. Well, maybe if we could expand a little bit on the process you've gone through here. I know you have been in discussions with staff on one of the committees of jurisdiction, Ways and Means, which your boss is a very senior member. I thought it was interesting and a positive thing that they actually suggested that we include another part of the old PCQ-CA bill, which was related to healthcare professional education and such, to make sure that the providers knew how to use the codes and also were familiar with this kind of advanced care planning counseling. Do you want to comment on that and then maybe give some context for how the bill might move forward?
Yeah, so when I had reached out to committee staff originally, we had only had the first two provisions, and they had suggested adding this language because they were like, it's a relatively newer thing when we're talking about the grand scale of healthcare, and providers are already can be kind of squeamish about the conversation. So making sure that they had that education was going to be a key part of making sure that access is there, because it's really about how can we reduce barriers on all fronts. I have learned a long time ago to not read the tea leaves when it comes to what Congress is going to do and what the chances of getting anything done are, especially when we are looking at an election year and we don't know what's going to happen and what the kind of state of play is going to be. But I hope that we can show that this is relatively non-controversial and is really about making equitable access to the service. And I think something the Congressman talks about a lot is just this idea that COVID has really changed the conversation around end of life care, because so many people unfortunately had to be put in this position where they were suddenly thinking about it in really dire circumstances. So I think the goal is that we can capitalize on that conversation to be able to move it forward.
Yeah, it's interesting when we've had an opportunity at C-TAC to talk to some Hill staff. They actually bring up the issue of, well, these codes aren't being used enough. And it's almost not quite a catch-22, but it's similar in that, we're trying to figure out ways to make sure that these conversations do take place. And if you won't, move forward with some of our ideas, then maybe the numbers will stay low. Do you have any Oregon kind of experience or knowledge in this space, advanced care planning, since the state is so forward moving on all sorts of fronts related to end of life issues?
I actually don't know if I have a good Oregon specific example or conversation to talk about, but like you said, I think the state has been really a leader kind of in this area on various fronts. And I know it can be kind of touchy, but I know that they love to talk about their medical aid and dying stuff, which is separate from this work. Yeah. I will be sure to clarify that. But something I'm really looking forward to talking about when it comes to the state work. So we, in the Medicare program, in the Medicaid program, we use something called a coordinated care organization, and they are implementing or getting started implementing a palliative care benefit through that. So I'm kind of interested to see what lessons we can learn from that to also, circle back to some of our other end of life work and how we can better address palliative care in the community.
Mm-hmm. Thank you. Jennifer, do we have questions that you've been able to see in the chat, or anyone raising their hand to speak?
So I cannot say from my side exactly, but I'm going to see if I can try to find it just to make sure.
I don't see any posted, but people are welcome to raise their hands and post questions. Jennifer Ballantyne.
Hi, I just put something in the chat. I'm curious about the latest data we have on the uptake of the billing codes. I saw some stats early on in the first couple of years after they were introduced, but I haven't seen anything recently. Is it continuing to grow, or is it kind of stalled out?
No, it's kind of stalled out. And I think that some of the last formal analyses have shown issues like the cost. Both a report done by ACP on advanced care planning and some academic articles have identified that providers are aware that there is cost sharing for patients and often don't even offer advanced care planning because of that. And, you know, I wouldn't say that the fact that other people can't bill for this, like social workers, is a huge factor, but it might be.
Yeah.
Yeah,
Thank you.
I see Catherine, you have your hand up. Go ahead.
I love the idea of expanding the role. I'm a pharmacist by training. I do a lot of advanced care planning conversations with my patients with palliative care and oversee our advanced care planning program within our MedStar health system, which covers both inpatient and outpatient advanced care planning providers or facilitators. We train our facilitators using respecting choices model, and I'm wondering, it's not recognized, but they are so well trained, and we've used a lay facilitator model and demonstrated it through a grant in partnership with Hopkins, and there's a couple of publications out, more coming on the model being successful. So just wanting to advocate for expanding to a trained person who's, if you've done training, it's been such a support for our physicians, and in this hiring, you know, tough time of hiring, to train up our lay staff in a way that they can support these conversations as more of like a diabetes educator, a navigator, peer support person has really broken down a lot of myths. And we have a really, as many of you do, a vulnerable population. So wondering if that's part of some of what we could advocate for to expand and improve.
No, that's definitely helpful context to have. And I appreciate being able to hear more about that going forward.
Yeah, I would concur with Catherine. I have in a research program that we're working with Dr. Kimberly Johnson, we're using community health workers who've been trained to use respecting choices, and through the clinics, they're getting referrals, and they are talking with patients about these decisions and how to walk through and begin to initiate these conversations. And then on the back end, redirecting them and helping the physicians sort of pave the way for those conversations to happen and for documents to be executed. So there definitely is a room. And when you talk about influencers in our communities, using those individuals that people are comfortable with, that can be an extension of the medical team, is proving very successful. I'm so impressed with the community health workers that we've been working with in 5 states that are doing this work.
Asha, maybe you might want to comment on the larger bill that you still may introduce either this year or next year, going back to the original PCQCA and seeing what is relevant, because some of these ideas we could funnel into your thought process.
Yeah, I think that would be really useful. I know the original goals of PCQCA, I think, still stand. This idea that we can have better upstream palliative care and better improve some of these services. And since we need to kind of revisit what the model looks like and how we approach that concept in a world where CMMI doesn't really want to do new models, I think that incorporating some of these concepts would be really great, especially when we're talking about, you know, our committee staff is very data driven. So being able to pull the experiences that you've had and across the board use some of these programs and utilize that as we're updating and crafting language, I think will be really great.
So Brian, I think there was a question in the chat, and one of the things that I would say in terms of certification and state laws, that there are wonderful evidence-based training programs around advanced care planning across the country. And typically what will happen is that you are going to defer to those state laws. So having that certification, and as we're educating providers about counseling with the codes, we also need to know that we still have a large number of providers who are not comfortable having conversations. So being able to couple training on how to have conversations and being culturally competent and initiating those in our very diverse communities is going to be key as well. Providers do tell us a lot of times it's not so much that they don't want to have those conversations. Some of it is the discomfort they have in initiating them, but also the processes in a practitioner's office. We were able to, in South Carolina, pilot a couple of primary care practice offices that were very large and busy, and basically do a care mapping of how to integrate advanced care planning into the workflow for the day. And that made all the difference in the world just by adding a couple of things whereby it would be top of mind, not just doing wellness visits, but when there are exacerbations of issues, someone's gone to the emergency room, and so now they're having a follow-up visit with their physician. And like you said, Asha, that follow-up visit, there should not be a copay, but now we should be able to have that conversation because there was an acute medical issue that occurred that we now need to revisit those goals of care. So.
Thank you. That's really helpful. Asha, we should let you go. We really appreciate you joining us today. Do you have any closing comments you'd like to make?
No, I just want to say thank you for having me. I really appreciate your support of this legislation. And I think one of the questions in the chat was how you as individuals or organizations can support going forward. You know, I'm doing my best to try to make this a bipartisan bill to kind of push it with our committee staff. So if you guys have members that are on committees of jurisdiction that you want to weigh in with them, if you have relationships with the committee staff on either side, and in both chambers, I'm going to speak for Colleen there, and would like to weigh in with them, you know, we would definitely appreciate that. And I will say, you know, end of life care is something that we're committed to beyond this legislation. In addition to it, I'm starting to kind of think through the ideas of concurrent care and hospice. So, you know, I welcome your thoughts and ideas in a variety of spaces, and just very grateful for the work that you do and the partnership we have.
Well, thank you so much for all your work. I mean, this is just, people may not realize how many hours go into these back and forth with legislative council with changes and improvements to the bill. And we appreciate your persistence on getting this done. And hopefully some of it or all of it will end up in an end of the year package or a mental health package. But either way, we'll be anxious to work with you on the bigger bill next year and whatever is not handled this year, reintroduction. So thank you again, and make sure you thank the congressman from C-TAC for all of his good work on this. Appreciate you joining us. Sure. Well, we're going to thank you again. We're going to turn to Marion, and you're going to, I think you've got a slide there, Marion. So we'll go there, and I'll try and catch up and see if there are any questions that I've missed while this section was going on. Thanks.
Thank you, Brian, and thanks to Asha as well. So, you know, we wanted to give you a little bit of inside the Beltway perspective about how this all came to be. There had been legislation that removed the cost sharing from advanced care planning that had been batted around and was introduced in the last session, but that was just one of many provisions in that bill. And we knew that this was an issue, but a couple of years ago, there came out a couple of academic papers, one that analyzed the billing codes that said, oh, so now interesting, who gets annual wellness visits? Well, it tends to be, you know, people who have access to primary care, and it tends to be people that get regular health care because they have the time to get annual wellness visits. And even though communities of color have no problem with an annual wellness visit, they tended to get advanced care planning proportionately more often outside of that event. And I think most of you know that the annual wellness visit is an annual opportunity for a Medicare beneficiary to sit down with a primary care provider and talk about a bunch of things, including advanced care planning. And when they talk about it in that context, and the provider uses that billing code, there is no cost sharing. The 20% Medicare Part B cost sharing does not apply in the annual wellness visit. So, I think when the codes were developed in 2016, I believe the thought was, well, who else? This is the only place generally where people are going to have these conversations, right? Well, now those of us who are clinicians, I'm a practicing palliative care and hospice nurse practitioner, we know that that is generally not the only place where the people have these conversations, but that's how the codes were established. So a paper came out that said, if you look at who is getting it outside the annual wellness visit, it tends to be communities of color. And oh, by the way, they have to pay this cost sharing. And if they are having the conversation with a specialist in the hospital, they are paying more than just a few bucks, So we recognize that, and a number of our members came and said, this is an issue. So we thought, all right, why don't we go and just have advanced care planning designated a preventive service? Wouldn't that be the easiest way to do this? So we went to the USPSTF, the United States Preventive Service Task Force. And they are the people that put out the guidelines. Every few weeks, there's a thing about whether women should have mammograms and when should people get colon cancer screenings. They are the people who review the evidence and they make that determination. And we submitted an application a couple of years ago that had all the evidence we could find packed into it. It was quite compelling that they should deem advanced care planning a preventive service. And they looked at that for a number of months. And then they got back to us and they said, yeah, we don't need to do this. It already is a preventive service in the Medicare annual wellness visit. And we were like, yes, it is. But when it occurs outside of that, it is not. And they said, we're not going to get into it. It already has been deemed a preventive service. We've moved on. So we were like, okay. And they kind of said, well, CMS Medicare made that determination. So we went to our Medicare contacts a year ago and said, hey, this is what we heard back from the task force. Here's what the data says. Can you guys deem it a preventive service in other contexts and just wave a magic wand and make this copay go away? And they went off and they talked with counsel and they took a number of weeks to study this, and they got back at a high level to us and they said, we do not have statutory authority to do this. So we ran into a brick wall on the regulatory side. And we were like, okay, I guess we're going to have to go to Congress. And fortunately, there had been enough talk in the offices that had the Patient Choice and Quality Care Act, the PCQCA, that there was interest in putting this freestanding bill out. So that is how it comes to be. And some of us are definitely have the battle scars from several rounds of this to show, but we are delighted that there is this bill. And we are hoping, as Brian said, that it will find a home somewhere in any of the big votes that happen over the next few weeks and months. They have until the session ends, which will be the end of this calendar year. A lot of things will go on hold because of the midterm elections. But this is one of those issues that, because it has been bipartisan in the past, and it's been bipartisan even now, we have a bipartisan co-sponsors in the Senate. We're hoping that this will find a place. So I just wanted to share that story with you. I'm happy to answer any questions about that, but this actually got started with the cost sharing, and then once the offices were interested in introducing it, then we said, well, if we're going to do that, we might as well add social workers, we might as well add education, we might as well add a study. So that's how the bill comes to be the way it is. And now I will hand it over to Maraset Hassan to talk further about the impact at the community and the provider level.
Looks like there's a question in the chat about, is there any hope for a national registry for advanced directives in this effort? Man, wouldn't that be good to be able to connect everything together? But
that would be great. But to my knowledge, there has been legislation advanced previously on this topic, but it has not been introduced this session. And at the moment, that doesn't seem to be where the energy in Congress is. But we agree that that would be a lovely thing. And even state registries would be a lovely thing, but they are expensive to start and maintain. And so not even too many states have them.
Yes, yes. Thank you, Sylvia, for sharing that you guys are working on this in Ohio. And we are aware that there is a lot of work being done at the state level where there are registries for post as well as being able to upload advanced directives. And so that work continues. And hopefully we can get the work that the states are doing to bubble up to the national level where all of these systems can talk to each other, right? So that is definitely the goal. And yes, Catherine, I see your comment too as well, as the HIEs in states are doing that as well because they are connected to the health systems. And we're very familiar with how health information exchange is being utilized across the state, especially when you have the large electronic medical records like Epic and Cerner, all of them. People can talk across the country, and to be able to connect the registry to those, and being able to open that up, that is going to be really good. I will share with you that we heard recently that Five Wishes now has an online platform with their booklet, The Five Wishes, which in the past was sort of clunky, right? Because of the pages and having to upload those. They're recognized as, their booklet is recognized as an advanced directive across the United States. And so now with their online platform, anyone across the country can look in and be able to see what's out there. So lots of advances being made in this area and definitely more to come. So I want to just chat with you a few minutes around looking at how this legislation is going to impact our community-based organizations. Very excited and passionate about this, as hospice has been a part of my life for 30 plus years. And so either working on the provider side or working, with providers. And so I'm really looking forward to it. As we look at increased utilization for the LCSWs, I have LMSWs here, but LCSWs and access to our under-resourced communities, this is going to definitely be a game changer. When you think about the fact that we have workforce shortages with nursing, and nurse practitioners have really allowed us to do more in the community-based space in terms of being able to visit people in their homes under Part B. But if we can add the social work component and where they have the time to really talk with patients and families and be able to bill for that, I think that is going to really increase utilization. Not to mention the social workers' ability to actually also partner with some of the community organizations to raise awareness. I believe we've got to do more community collaborations and partnerships to raise awareness so that people are ready before they have an illness to have this conversation because they've heard about it ahead of time. We want to be proactive. I truly believe in the enhanced physician education and billing resource tools. We have heard physicians say we have so much on our plate at the primary care physician level. We know that with our specialists, some of them are really partnering with palliative care right now. And so as they're partnering with palliative care, they are having those specialty clinics where that allows them to really touch some of those patients. But to be able to do this outside of the wellness visit is going to be a game changer, but also helping physicians and their billing teams know how to bill for these conversations with the codes, to be able to look at that is going to be really key. I want to really underscore the need to help physicians and their staff understand about why advanced care planning is so critical and why we need to know how to engage in these conversations. It's important for us to understand the culture of the people that we want to reach. And so in some cultures, this isn't a conversation that's an easy conversation. And so it goes beyond, as we think about health equity, we also need to think about the makeup of our physician practices and what are we doing to work with those particular groups, our fairly qualified healthcare centers, our rural healthcare centers that are in communities where we have a lot of representation of communities of color, and to begin to those partnerships because they have influence with those communities. So we've got to kind of come out of our silos and get engaged with community. So as I talked about those partnerships, you can tell I'm excited about that. We really do need to have bridges to communities that are serving the people that we desire to reach, and really think outside of the box. Could I partner with a faith community? Could I be doing something with AARP, who has a way to drill down on zip codes and can let you know who lives in particular areas? Could I be doing something with the Alzheimer's Association? So thinking outside of the box is how we can raise awareness. When this bill is passed, we want to touch and communicate to everybody in the communities that we serve how this can be impactful. And certainly with eliminating the copays, this is really going to be important. I will tell you a personal story that recently, about a year ago, my husband just became Medicare eligible just about 2 years ago. And last year he had a traumatic, episode with COVID where he had to be hospitalized. He did not have to be put on a ventilator, but he had all the long haul COVID symptoms of that horrible cough for several months. And of course, he is male, does not want to go to the doctor, right? And so they began having conversations with him after his hospital stay about the need for him to put an advance directive in place. Now, I'm a nurse and have worked in this field for a while, but I couldn't get him to do one. And so now we're having, these conversations. But he's had to also, have to have other kinds of visits. And so when you think about how those copays add up, and on top of people having to pay for medications and the copays related to their meds, and we have insurance, but we also have to pay the copays for medication. We have to pay copays for, these conversations. If you go to see a specialist, there's a copay. So when you think about our communities of color, many times there are comorbids. You've seen the statistics. So they're not just going to one physician. They may have several specialists that they're seeing. So if everyone is beginning to then have a conversation, then the costs are adding up. So the ability to eliminate these copays is going to be critical. And it's really going to help us be able to talk with more people at critical times around the need to, number one, talk about what matters most to them, and number two, to begin to have that conversation with the people who matter, and then get to a document. I think sometimes we want to get to the document first, but we must remove the barriers of conversation first, and then we can get to a document. So, Brian, I'm going to turn it back over to you. Those are my thoughts, and we're happy to entertain any questions you have.
Sure. Well, first, let me just answer one question, and that is the committees of jurisdiction related to this bill. On the House side, the Ways and Means Committee, and Asha's boss, Representative Blumenauer, is a key member of that committee, is the primary committee of jurisdiction, but the bill was also referred to the Energy and Commerce Committee. And the way to think of it is Energy and Commerce has most of Medicaid and a little Medicare, and Ways and Means has most of Medicare and a little Medicaid. So it's primarily Ways and Means. On the Senate side, it's the Finance Committee. And of course, you know that Senator Warner is key on that committee. As was mentioned, we do have bipartisanship on the Senate side with Senator Collins signing on, and Asha is waiting to hear from a number of offices on the House side, but since the Senate bill was ready to go, Blumenauer went ahead and introduced his bill on the same day. Does anyone have questions for either of our last two speakers?
Yes, Jayla Sanchez from Colorado has a question.
Yeah,
Jayla.
not really a question. I just want to totally agree with what you said. I run the Area Agency on Aging in Denver, and working with community-based agencies is so important. You know, we serve Native Americans, we serve refugees from 8 different continents and countries. Talking about, we've been talking about or helping people with advanced directives my entire career. So that's 35 years, right? But it is really important to understand what those cultural differences are and how to approach these conversations. Because if you approach them the wrong way, sometimes you only have one chance in doing that, right? And if you approach the wrong way or don't understand the cultural differences, then you've lost your opportunity. Also, you know, long-term care ombudsmen have been doing this. We got direction several years ago from the administration on aging. So you know how long ago that was. Now the administration on community living to talk to residents about advanced directives and making sure they were comfortable with what they had. And we found that so many residents in nursing homes had advanced directives, but didn't really know. No one had sat down and really talked to them about what that meant, right? And they didn't realize they had the opportunity to change them as well if they wanted to. And so I think that's really important. It's not just a one-time conversation, it's an ongoing conversation that you have to have with people and particularly older adults. And sometimes they're just not ready. And then maybe, you know, 6 months later, they are ready to talk about it. And important to talk about, if you don't have these, then this is what's likely going to happen to you without your consent. And that tends to, you know, people say, no, I want to have some input into that.
We so agree with you on that as well. And as you talked about the different cultures, Native American, Latino, you know, as you think about all of that, have you guys in your particular organization there in Colorado, are you utilizing people from those communities to help you? Or you've trained internally your staff? Okay.
No, absolutely. And we want to do more of that training because, like I said, we can't. Sometimes there are barriers that we just don't understand. We serve people from several parts of Africa, right? And there's differences there. And we have to use people in that community. One, for the language barrier, we don't want to get that wrong. And then the cultural differences that are so important. And these folks, especially our refugee folks, you know, they tend to underutilize healthcare services. We did a study a few years ago. They don't utilize healthcare services. There's usually, when they do, they have usually a 9-day stay in a hospital and a 62% morbidity rate, which, so you know, they're at their last, you know, the last days of their lives there. Important for them to understand, and for the care providers, the hospital staff, to understand their particular needs, to make it as
I think we lost her. Maybe she hit the mute button. And so I think what she shared with us has just been very, very informational in terms of how we can go about engaging with the community. So there's a question now, Marion, in the box. Do we have support?
Just let me just jump in if I could, just to stay on that track for a second there, Marissa.
Okay.
I just wanted to mention, first of all, C-TAC and our team we're very big fans of Jayla and her program and all the great things she's done. But we're also working at the national level with US Aging, which used to be N4A, the National Association of Their Agencies on Aging. And with US Aging, we're working on two things. One is that relate to today's discussion. One is we're working on a project that the John A. Hartford Foundation funded to identify best practices in advanced care planning programs, models, and activities out there, and to develop tools and information to share broadly. And we're just at the beginning of that project. And then secondly, we've been working for a long time to try to get some resources from the healthcare side of our brain over to the social services side, so that Medicare and Medicaid could actually be funding more supports and services at the community-based level, particularly with AAAs. And one of the things in this bill, the social workers, we think is possible that down the road, social workers within AAAs who are doing assessments and care coordination might be able to do this advanced care planning with older adults with serious illness and then be able to bill for it. So I'm sorry, Marissa, you saw another question.
Yeah, I'm happy to answer the question about support from insurances to waive the cost sharing. So that's a wonderful question. And interestingly, a number of payers have been waiving the cost sharing on their own because they could, right? But of course, having this be federal policy would make it easier for other healthcare insurance companies to waive the cost sharing. And, again, they aren't required to if it's non-Medicare patients, but usually what happens in Medicare can help, change policy for even the commercial market. So the answer to that is some have already been doing it, and we hope that more would now be encouraged to do it if this actually becomes law and changes federal policy.
Mm-hmm.
There was also a question before that about an add-on for ACP services in home health care. I just want to make sure you all saw that.
And could you repeat that, Jennifer, in terms of in home health care?
So, and maybe Kathy wants to ask the question as well, but it was as an LCSW and HIP social worker, I have found the benefit of having these conversations within the home health care benefit. What about an add-on for having advanced care planning conversations in home health care?
Yeah, so one of the things I would say about that is just like with hospice and home health are covered under Medicare Part A, and this is under Medicare Part B, thinking about the process of that under hospice, and I'll start there, these conversations happen pretty regularly, and if they aren't happening tied to a particular patient, there is a mechanism for billing to occur. I'm not as familiar in terms of with home health, and particularly with home health, a lot of our social workers aren't always brought in all the time, in terms of how those services are. And so I definitely agree with you that there should be an avenue for those conversations to be had and have an additional payment for that. Some home health agencies have started to work on palliative care and create a separate arm where they're able to do some of that work. But through the home health agency, there's not that mechanism for extra pay. The social worker could initiate those conversations when they're doing their social determinants of health assessment, including that as a part of one of those questions, right? But I don't know what we would need to do in terms of taking that track to bring that into the Part A environment for home health, but something to think about. So,
but to build on that, Morris said, I think you raise a good opportunity. Somebody posted that unless there's a social need, we can't add the social worker to the team for home health. And that is true, except that now all these federal programs are going to start requiring these programs to monitor for social determinants of health, to assess for social risk factor. Now that's mandatory in a few things yet, and in others, Medicare has asked the question of, if we were to do this, how would we go about doing this? And C-TAC has commented every time we've had the chance to say, yes, we should be assessing for social risk factors and for social determinants of health. So my hope would be that doing so, even in home health, might uncover unmet needs that might then allow for the the involvement of a social worker in what has traditionally not been an interdisciplinary type of care.
Mm-hmm, absolutely. And we know that CMS is going to be looking at how to measure impact on health equity related to home health and to hospice. So this is going to be an open door with the technical expert panel to really look at how we evaluate our effectiveness in our communities of color. And so I agree with Marian that there now is going to have to be at least one visit by the social worker, which is more than what some patients may get under home health if there's not a social need, that this will really dictate to how agencies now begin to get that information, because the social worker is going to be far more prepared to do more of that than the nurse is going to be, or the physical therapist, or the speech therapist, et cetera. So we certainly, we will definitely be thinking about that and seeing what we can do. So thank you for bringing that up. Other questions or thoughts? There was a comment about a revision of a tool that Ariadne Lab is doing. And I am very familiar with the fact that right now they're working on a race dialogue tool to begin to train clinicians on how to incorporate race, because sometimes the racial piece is a barrier because of trust issues. And how do we begin to deal with the elephant in the room when we engage with patients on a clinician patient interaction? So they are working on that tool, and we'll have some things to share with us about that, I'm sure, in the coming year. So definitely am aware of that.
Marian, there was a question earlier that related to the potential, there were a couple questions, the potential of others beyond clinical social workers. And since you're a clinician yourself who can bill and does this, I thought maybe you could address the issue of making sure that we can't open this to everyone. What are the issues around training and other conflicts that we face beyond social workers at this point?
Yeah, so thank you, Brian. I mean, I'm a palliative care hospice person. I love working in an interdisciplinary team. I wish that Medicare would just be able to wave a magic wand and let nurses on a team, chaplains on a team, pharmacists on a team, people who are interacting with patients and families have these conversations and have them be reimbursed for them. I think we just have to recognize that there are a number of structural impediments with being able to do that. And so we were able to start with social workers because they already do bill as Medicare providers. And with so much interest, frankly, on the Hill about behavioral health. Now, of course, with the pandemic, it's revealed yet another thing that we knew but didn't really know how bad it was, which is the need for mental health services for the country. So they have been doing a number of things, both they and the administration, to allow social workers to be more engaged, at least in behavioral health. But we took the opportunity to say, well, advanced care planning is counseling, so how about that as well? But I think there was a structure already in place for that. There is not a structure in place for some of the other members of the interdisciplinary team. That isn't to say that we have given up on that. You can see our conversations with these congressional offices. We speak often with them. They are aware of some of these opportunities and needs. I think the other way we've been advocating for more members of the team to participate in these conversations is promoting value-based payment arrangements. So if your organization, your program, or your team were to get some kind of ongoing payment, a monthly payment to take care of a person with serious illness, then it's not fee for service, which is advanced care planning billing codes is still fee for service, right? You did something, you got paid for it. If we move into more value-based arrangements that allows team-based care. And so if you're getting an amount every month, it doesn't really matter who on the team has a conversation. Obviously, it should be somebody who has skills and training to do that. But whomever meets that criteria could have those conversations and help, contribute to the team-based aspect of care. And the value-based payment would pay the full team for their work. And so you wouldn't have to argue over, well, you're better at it than I, but I'm the one who can bill. So I think for the foreseeable future, those are the paths that we see. And again, it was only because there's so much interest in behavioral health and social workers from that allowed us to once again get enough, interest in including social workers in this bill. Brian, would you have anything else to add from a congressional strategy standpoint?
No, I think that's right. I think that there's a real concern that about the cost of this bill and how many more people will take advantage of having these conversations. Anytime you talk to one of these key committee staff about allowing someone else to bill, they freak out. That's the bottom line. And we need to be really careful about that and make sure that we have the very best evidence that we are moving forward payment to the people who are really good at this and who have been trained appropriately. So it's a tricky business, but we think that at least for now that the licensed social worker is the one that we're probably in the best shape with in terms of making that argument. I wanted to just add one thing. I know we're running out of time. I don't mind going over, but I just wanted to say, please let us know if your organization would like to be a supporter of the legislation, and we'll add you to the list, and we can connect you with the staff people and make sure the Hill offices know that you're a supporter, and you'll end up on their list as well. And you will be hearing from us at some point about some advocacy when we're going to be working to get some more co-sponsors. So we do have a good list. We have AARP and we have C-TAC, obviously Leading Age, the National Association for Home Care and Hospice, National Partnership for Home Care and Hospice Innovation, Respecting Choices, U.S. Aging, the Social Work, Hospice and Palliative Care Network, Smarter Healthcare Coalition. So anyway, we've got some great supporters. We're going to get a lot more. And if you're interested, let us know.
Okay. Brian, before we close out, there were 2 questions in the chat that are similar, and I want to make sure that we discuss these next steps and action items for folks, which is, again, what's the best way for them to, amplify the bill, provide support, in addition to reaching out to the members who might be on the committee that you mentioned earlier. I also know we have Jim from our C-TAC team who handles a lot of our communications as well, who's including some links in for organizations to sign on, but wanted to make sure that you gave that that response so we can talk about what our next steps are.
Okay, thank you. And I guess real quickly, one, let us know if you support the bill, and you'll be hearing from us about our advocacy efforts. We're working now on a letter from the Leadership Council of Aging Organizations and some others to add to this push. We're not sure yet how much can be done between now and the end of the year, but we will have a plan shortly that we'll share with people who are on this and call, and also C-TAC members. Moving forward, I think the other thing is, if you have ideas that this stirs, or that you thought of when we were talking to Asha about a bigger bill down the road, this isn't the whole package of advanced care planning provisions that we had in the original PCQCA. So if you have ideas in this space broadly, please let us know, communicate those to any of us, and we will work on those with Asha and Colleen as they look forward to reintroducing the bigger package at the beginning of the next Congress.
Thanks, Brian. Before we close out, unless we have more questions, as Brian said, we can definitely extend it, but I wanted to make sure that I took the time to plug the C-TAC Summit, which is happening in a couple of weeks. October is so soon. If you haven't registered already, please do so. It is going to be in person in DC. As someone who started with C-TAC remotely this will be like my first opportunity meeting a lot of the people who work on my team. So I'm excited about that. So would definitely be very much interested in meeting the rest of you all in person. So please be sure to register in case you haven't already. All right. Well, seeing as how we don't have any more questions, I want to thank Brian, Marion, and Marisette for being on with us today. And Asha, I know she's not on anymore, for being on with us today to talk about this. This is monumental work that we've been putting in a lot of work and effort into, and we're really excited to see that it's coming to fruition. It's one of the things we say at C-TAC, we actually never take our victory lap. We just kind of do a thing and move on to the next. So really want to just take that opportunity to thank everyone for their work on this, and also thank you all for logging on with us today to learn more about this and the ways in which you all can support the bill and additional efforts related to ensuring that people receive high quality care how they want it, where they want it, when they want it. Again, I want to just thank you all and enjoy the rest of your day.